Can I just say, while we're waiting for people to finish being admitted, thanks to everyone for joining us today. I think this is a particularly important area of work because we know how harmful tobacco is. And during pregnancy, you're dealing with more than one life being harmed by tobacco. It's good to be hearing about some of the cutting edge research. It's good to be hearing about some of the experiences on the front line. What we're going to do today, and welcome to you all, is we're going to have 3 presentations. So I'd like to welcome in advance Marianne White from NHS Tayside, who's going to talk about the Clearing the Air project, Dr. Scott Hogg, who's a GP in NHS Scotland, and Montse Valverde-Giberno, who is joining us from the Institute of Oncology in Catalan to talk about some cutting edge research on e-cigarette vapor and the effects during pregnancy. So we will hear the presentations. I'll leave a couple of minutes at the end of each, just in case there's any burning questions about that particular piece of work and presentation. But if you can save most of your comments, questions and discussions, either put them in the chat as we go, save them till we get to the end, then we'll open up the discussion and have a bit of a chat. So welcome to Marianne White from NHS Tayside. If you could get ready to share your slides, and we'll hear about the Clearing the Air project overview. Thank you. So we did find in rehearsals that slide sharing can take a little time. There's a slight lag. We're not seeing anything yet, but I'm sure we will in a minute.
Can you see that now?
It's just coming up. Okay. I can see the slides now, Marianne, yes.
So this was a project that I started 2 years ago with my senior charge midwife, Steph, and also we worked with the tobacco control team in NHS Tayside, which are based in public health. We wanted to first identify how we could encourage pregnant women to stop smoking. We did quite a lot of work in the discovery phase of this project, understanding where we were and what we needed to do to best support the women within Tayside. And then we wanted to set our targets to be achievable within the time frame we had. And so we wanted to increase the number of women who received carbon monoxide monitoring in pregnancy to around 80%. And then we also wanted to promote access to tailored smoking cessation programs by the end of the year. Tayside doesn't have a very positive journey in terms of smoking in pregnancy, and the number of women that enter pregnancy smoking has remained unchanged for over 10 years now. And we have over 14% of women entering pregnancy smoking, with the Scotland national average around 11%. And when we looked further into what we were doing, we found that only about 4% of women were actually receiving the recommended carbon monoxide monitoring through pregnancy. This is at booking, at 36 weeks, and then at birth. And if you smoke, you should have your carbon monoxide monitored at every visit just to help support you. So, and then when we looked into who we referred to smoking cessation, we realised that only 1 in 30 smokers were actually referred, and only 1 out of 4 of the women who were referred actually managed to reach this quit rate. So we realised we had quite a lot to do in recognising who was smoking in pregnancy, how we could make this referral pathway easier for staff, and also how we could support women better to stop smoking. When we looked further into it, we had a stillbirth report that had 80% of women who had a stillbirth within Tayside lived in SIMD 1 and 2. This is the highest areas of deprivation. And then when we look further into it, 21% of women in SIMD 1 and 16 in SIMD 2 smoked. And so we realised this was a preventable part that we could do to support women. So our plan was to have a look at what was going on, to go into each area of maternity services within Tayside. So that was within Angus, Dundee and Perth. We designed a driver diagram to realise what we needed to do and what our change ideas would be. And we also mapped a patient's journey with women who smoked and the journey that they went on, which could be very different for each woman. We also further went into understanding staff views by using empathy mapping and understanding their views, and I'll show you that later. Part of the project was to design a measurement plan and then also produce data which we could show staff for improvement. And why was this important? It's really important, as I'm sure most of you know, to reduce smoking in pregnancy. It's got harm to the mum, so she's much more likely to experience a miscarriage, ectopic pregnancy, and have placenta that isn't inserted correctly and that's a bit more dangerous. And she's also 27% more likely to have a preterm birth and have thrombocytis. There's also harm to the unborn baby, so there's much more likely to have stillbirth, premature birth. The babies are much more likely to be low birth weight with growth restriction. And then there's also a higher chance of neonatal death and sudden infant death. So we knew this was something important we wanted to work on. I designed a ridiculously large measurement plan because this is all the measurements we can actually get from our electronic system within maternity. But actually understanding what was achievable for the teams on the ground, I realised was more important. And so these were our outcome measures and our process measures. We wanted to measure carbon monoxide monitoring at booking, how many women were referred to the services, and how many completed the services. This is an example of the empathy map we did. This was one we did within Perth. We put it on a board and just let staff write what they thought. We realised they had a lack of understanding about the knowledge available about smoking and vaping in pregnancy. They weren't really sure what to say, and they really wanted more information so they could support women. The problem was they just didn't know what to say. They didn't have enough carbon monoxide monitorings, they didn't know where to order the disposable parts, and they didn't know how to use them. They didn't know how to refer to smoking cessation, and also the process to refer was quite clunky, involving paper and around 5 clicks on your computer until you could find the sheet of paper that you needed to print out. So we knew we had to do something different, and it was really good to listen to each staff group within each area, and it was different within each place. We started doing run charts about carbon monoxide monitoring, and this is the one in Perth that the midwives monitored themselves, and every week they would see how many women they had monitored, and they understood the barriers faced by some midwives and why things weren't happening, and it really helped for them to understand their own data. Along the timeline, we also introduced a number of things, and we used this at training to help support staff. We introduced carbon monoxide monitors, which was a baseline of how to support staff. We sent them information. We went into the clinics every week, and with the tobacco control team linked in with every community midwifery unit within Tayside each week. We also worked within the specialist clinics, such as the enhanced care midwives, who saw antenatal women in our antenatal clinic within 9 Wells. And it was just interesting to realise that when you broke down each area, it was quite different. Most of the units were recording carbon monoxide under 10% before we started our project. And we went into the units and asked them what did they think they could do better, what were the barriers, and how we could support them. It gradually increased each week. When we went into Perth and Kinross, they really embraced this. To begin with, they said they didn't have any women that smoked, and then they understood that we do have women, there's pockets of women in each area, and it's really important to provide the support, and they really took this on board, and they've remained over 80% throughout the whole project. And then we had Dundee, who it didn't really take off. They've got a different way of working. And so it was really important not to kind of take an intervention for one area and put it into another, but understand how the teams work, where their monitors were kept, how their clinics were organised, and then share the importance. So we shared journeys of women in the neonatal unit who had smoked, had a preterm baby, and then the difficulties along that postnatal journey for them, and the fact that they didn't have any information or choice about smoking cessation. So it was really important to share this with them. And then we also put it into P charts so we could monitor Tayside as a whole, and we could really show teams how carbon monoxide monitoring at booking
Nina
was.
sent an email.
So what did we do in a whole? So we worked with the smoking cessation teams in our community, which are based in the pharmacy, and the tobacco control teams did a great job in bringing them on board and asking them if we could change our referral pathways. We acquired carbon monoxide monitoring, and we had robust mechanisms for ordering the consumable, which is really paramount in order the service is sustainable. We then designed an online referral, so we've got, you could, at a click of a button, you can refer a woman to smoking cessation, so you could refer them to the tobacco control team and or the local pharmacy. This means that they can go straight to the pharmacy, they know who they are, and they can provide smoking education. We also did a lot of education and training with staff, and we provide an updated guideline about smoking and e-cigarettes in pregnancy, and this was co-produced across our community. The other thing we did was the tobacco control team sought incentives, funding for the incentive scheme, so that we can provide women who stop smoking in pregnancy £500 if they stop for 12 weeks, and also their birth partner or household member can also have this financial incentive just to help them smoke and to help encourage them and support them along their way. So we're not there at all, but we're getting there. And what's important is that we've started to make things better, and we're working with the teams on the ground to make sure we can do that with them. Thank you. Hopefully I've come back now to you and not sharing my screen anymore.
I'm still seeing the screen sharing at the moment, but
just takes a few minutes.
It takes a few minutes. Meantime, Marianne, thanks so much for the presentation. I see there's a question in the chat from Liz in Public Health Wales asking, is Badgernet used in every area of Scotland?
It's used in every area apart from Lothian. So just one of our boards doesn't have it.
Thank you. And are there any other specific questions that people want to ask about that presentation, or can you hold the more general ones into the chat or for the end? Right, I don't even know if it is worth me trying to share a slide on this. It might just slow us down. Let me see where we've got to. So our next speaker, and thank you for that fantastic start, Marianne. Our next speaker is Dr. Scott Hogg, and I will share this slide just to let you get your slides up and ready, Scott. And Scott is a GP who, I think you're now sharing, Scott, who's going to talk to us about his experience with women smoking, vaping, cessation in pregnancy. Thank you.
Thanks very much. Can everyone see the slides there? Is that okay?
We can, yes.
So thank you for the introduction. As I say, I work 3 days a week as a GP in Edinburgh, a kind of mixed demographic practice of about 11,000 patients. And for the rest of the week, I'm involved in health policy research, mostly related to tobacco and the commercial determinants of health. I suppose just to start, I'm going to flag up that I don't have any relevant conflicts of interests, and I am a board member for ASH Scotland, who are hosting this event on a voluntary basis. So I can see in the kind of attendees, there's a lot of experience and background knowledge of this subject, and I'm really going to focus on my perspective as a GP. I'm going to mention just briefly why, from my perspective as a GP, I see this as such a significant opportunity in healthcare, delivering high quality smoking cessation in pregnancy. A little bit about the role of general practice in a patient's journey through maternity care, and then a little bit of discussion of the importance of standardising evidence-based recommendations to pregnant women, and a few reflections at the end on e-cigarettes. So I think in general practice, we have one of the broadest remits in healthcare. We look after patients of all ages. We look after, physical health problems. We look after mental health problems. And often that encourages us to reflect on where we can have the biggest impact, where the biggest wins are. And to try and illustrate this, I've put this graph together. So on the vertical axis there, we have kind of magnitude of potential harm that a presentation might have. And then on the kind of horizontal axis, I've got, well, what is the opportunity to intervene and do something and make a difference for that issue? So two very different presentations here that we see in general practice. So firstly, we have at the top pancreatic cancer. And if someone presented to us with symptoms suggestive of pancreatic cancer, it is very, very clear the magnitude of harm that could be related to that. Very high morbidity, high mortality, a very horrible disease. But unfortunately, at the time somebody has symptoms and presents to us, the opportunity for intervention, the number of treatments available, are usually relatively small. Compare that on the complete opposite end of our general practice spectrum, the fungal toenails. There are treatments for fungal toenails. Terbinafine tablets, a few months, you'll be great, you're sorted. But in terms of the magnitude of harm, the impacts that we're making treating fungal toenails in NHS general practice, it's not comparable to anything else on grounds of morbidity and mortality. While I appreciate for the person with fungal toenails, they do matter, and they do look very unsightly in holiday sandals. But I suppose the reason I put this together is I think smoking in pregnancy really sits in this absolute golden zone of opportunity where we know, and particularly some of the slides Marlene put up, about the extensive number of risks associated not only for the pregnant woman, the woman in her future life after decades of cumulative harm from tobacco, and also from a perspective of fetal health and the child. So huge opportunities for harm, but importantly, these are almost all preventable. I put two kind of statistics there. The first comes from a large kind of prospective study of about 1 million women over the age of 40 in the UK. And what we demonstrated was if a woman stopped smoking before age 40, and that is in the age of reproductive health, that is the age people are presenting in pregnancy, then if we stop smoking before that age, we reduce by about 90% the smoking attributable mortality across the life course. So an enormous impact to avoid almost all of the mortality associated with smoking. And looking more specifically at smoking in pregnancy, the second statistic there comes from the New Zealand and Australia SCOPE study. And this demonstrated that if we support a pregnant woman to stop smoking before 15 weeks gestation, their risk of preterm birth and small for gestational age is the same as a non-smoker. So clearly an enormous opportunity for modifiable risk, perhaps one of the greatest opportunities we have for impact in healthcare. So thinking about what that opportunity looks like in practice, this is the standard course of maternity care in Scotland as per the Scottish Government's pathway. And something to pick up there, we're seeing even in a low risk, uncomplicated pregnancy, we're expecting a minimum of 16 healthcare contacts. So what an enormous kind of open goal to have an opportunity to make an impact in terms of health promotion, multiple contacts, and something really important that we can do to help people to stop smoking. And where do GPs sit within this? So gone are the days of GPs providing lots of direct care to pregnant women and even delivering babies in their own homes. Now care is mostly led by maternity services and community midwives, and a named midwife. But GPs are still involved in lots of other areas. And so we know that in that period before a person's initial booking appointment, often a patient will have contact with their GP. They might also ask for advice before conception. And when we think about that 15-week gestation kind of goal of smoking cessation, then clearly all of that time before the initial booking appointment is critically important in terms of getting the right support in place for women to stop smoking. On the left of the slide, you see we have GP team involvement in assessment of acute illnesses and other health problems during pregnancy. That might include GPs, but it may also include advanced nurse practitioners and other members of the primary care team. And then another kind of critically important part of GP involvement is postnatally. So we see often babies for their 6-week check, and we also provide continuity of care to women after their pregnancy and between that and future pregnancies. And something just to flag up there, unfortunately, although, or we know that although many people manage to stop smoking during pregnancy, up to 50% of those will restart smoking afterwards. So again, that's a really, really critical time for intervention. And I think one of the things I wanted to highlight with this slide is actually care in pregnancy is truly multidisciplinary. We have multiple different professionals involved, and no matter how hard we try to achieve continuity of care, ultimately there are many different professionals at many different stages of the pregnancy who are involved. And I think that for me highlights the importance of ensuring that we provide consistent recommendations that are based on evidence to provide a clear advice to pregnant women and support them to stop smoking. And I think 2025 is a good year to appreciate the risks of misinformation in smoking in pregnancy and other issues of pregnancy. And in terms of what evidence-based recommendations are for providing clinical smoking cessation advice, I think compared to many other national contexts, Scotland and the UK are very lucky in that we do have very well developed guidelines. We have just earlier this year, the NICE clinical knowledge summary on smoking cessation in pregnancy was updated, and I would suggest that's a really, really helpful resource for a summary for clinicians. There's also helpful resources from RCOG and the Royal College of Midwives. And I think later in this session, ASH Scotland are going to flag up some of the new resources that we've produced that can be helpful for additional learning in CPD. And I suppose in all of the different guidance, there are some points of clear consensus and some headline advice. I suppose the first, as with all aspects of care we provide, and particularly important in care during pregnancy, that we have a person-centered approach that respects patient preferences. In terms of what we offer and advise and support people to engage with, the two main headlines are the things that we know work. We know there is extensive evidence for their effectiveness, and that is behavioural support, and ideally delivered through a formal stop smoking service. And also for some women, medically licensed smoking cessation products. And we know that using both together increases your quit rate by about 3 times. I suppose that moves on to the next point around e-cigarettes. And I think in this presentation, I'm focusing mostly on the frame of e-cigarettes as they are seen in smoking cessation rather than in people who have never used tobacco and are using e-cigarettes. And of course, the role of e-cigarettes in smoking cessation, there is not quite as clear a consensus on. And I think my own reflections on this is that it is quite different to provide an individual clinical recommendation to one person who you're looking after as a patient, compared to providing policy recommendations at a national level, which have to consider a lot of additional factors, including harm potentially to others in society who do not use tobacco or e-cigarettes not used as a quitting tool. And I think my main kind of points on how we should approach when patients ask us about e-cigarettes is really just to share and explain what evidence is available and what limitations there are also to that evidence to ensure that they can make an informed decision. And as part of that, also highlighting the other options available, behavioural support and licensed medical nicotine. And one of the ways that I think is quite helpful to frame that conversation with patients in terms of the different options available, and particularly differences between medically licensed NRT and e-cigarettes, is to focus on what each of those products have in terms of their regulatory background, the way that they're produced, and I suppose some of the things summarised in this table. So patches, gums, other forms of nicotine replacement therapy have had a robust assessment by the MHRA process that demonstrate evidence both of their safety and their effectiveness as a cessation tool. And while there is some evidence that e-cigarettes can help people to stop smoking, they are principally developed as a recreational product. And I'm not aware of any jurisdiction in the world where an e-cigarette has achieved a medical license for smoking cessation. I suppose some of the background to that, licensed nicotine replacement therapies are produced by the pharmaceutical industry, which is a very tightly regulated industry and only allows the sale of a restricted number of licensed products. Comparably, with e-cigarettes, there are a large number of manufacturers. There's variation between products, and we know there is a lot of involvement from the tobacco industry also. And I suppose in access terms, licensed nicotine replacement therapy is free to access, and e-cigarettes have to be purchased. So just a few points that I think are helpful in framing the differences between e-cigarettes and licensed nicotine products to patients. And perhaps if there are more questions, that might be a good opportunity to explore as part of the panel session later. I suppose just to summarise those few points, I think smoking cessation in pregnancy offers one of the greatest opportunities we have to make an impact in healthcare. And from the perspective of a GP who works with lots of different health issues, that is very, very clear. During pregnancy, we have multiple health contacts, and that's a huge opportunity for intervention and support. But with all of the different people involved, it's really, really important that we have standardised evidence-based recommendations to provide to pregnant women and support them in stopping smoking. That's all I have to say just now, and I would be happy to contribute and answer any questions in the panel session later. Thank you.
Thank you very much, Scott. And I see a few questions coming up in the chat for Marianne. But if there are any specific questions for Scott on his presentation or his experience as a GP specifically, if you'd like to just let us know now. If not, hold it until we get to the discussion and questions phase and we can come back. Okay, let me see if I've got this. All right. So thank you, Scott. And we are now moving on to welcome Montse, who has studied passive exposure to e-cigarette aerosol in pregnancy and looked in particular at one particular family. So welcome, Montse. If you're ready to share your slides, I'll hand over to you. Thank you. That's great. We can see the slides. They may need to be in present mode. Okay. That's great. Thank you.
Perfect. Well, good afternoon to everyone. Thank you for inviting me to this interesting session. And well, today I'll briefly talk about secondhand exposure to tobacco smoke and e-cigarette aerosol with a special focus, of course, on pregnant women and children, as we usually say, during pregnancy, that we eat for two, but we also we breathe for two, so protecting clean air is essential. So I will start with passive exposure to tobacco smoke. And as most of you know, secondhand smoke comes both from the smoke exhaled by the smoker, called mainstream smoke, and the smoke released from the burning tip of the cigarette. This is the side stream. And this side stream is even more toxic, and its particles are smaller, meaning that they penetrate deeper into the lungs and enter into the bloodstream more easily. Secondhand smoke contains more than 7,000 chemicals, including at least 70 known carcinogens, such as benzene, arsenic, and cadmium, for example. So secondhand smoke is officially classified as a carcinogen. And importantly, there is no safe level of exposure. No? Even small amounts can cause harm. And globally, secondhand smoke remains among the top risk factors for disease burden, in fact, in the 14th place. And well, in fact, no, the exposure to secondhand smoke causes disease and premature death at all ages. In adults, increases the risk of heart disease, stroke, and lung cancer by up to 30%. But importantly, women are disproportionately affected. Secondhand smoke causes more than 5 times more death from heart disease in women than in men. And during pregnancy, passive smoke exposure is linked to reduced fertility, pregnancy complications, low birth weight, and preterm birth, for example. And in children, it decreases the risk of respiratory infections, asthma, ear infections, and even sudden infant death syndrome. So in total, secondhand smoke causes around 600,000 premature deaths every year. Moreover, secondhand smoke also appears to affect mental health. Around 2010, studies began to show a link between secondhand smoke and mental health problems. Here I show the first 2 major studies that identified this association, that you may know them well as they are conducted in Scotland. In healthy adults, secondhand smoke was associated with higher psychological distress and higher risk of future psychiatric illness. And also in children, the exposure to secondhand smoke was associated also with poor mental health, like, for example, depressive, anxiety, or hyperactivity symptoms. And this association remained after adjusting for several variables such as gender, age, poverty, maternal tobacco use during pregnancy, among others. And interestingly, in both studies, a clear dose response effect was observed, meaning that even low exposure levels matters. Since then, more studies, including some we have conducted in Spain in our unit, have confirmed these findings. But we also know that exposure is not equal for everyone. People living in lower income households are more likely to be exposed to secondhand smoke indoors. And this figure from Spain's National Health Survey shows that lower socioeconomic groups are less likely to live in smoke-free homes. And the intensity of exposure is also higher in disadvantaged groups. As shown in this graph, using the same data, people in lower socioeconomic households are not only more often exposed, but also exposed to higher intensity levels. So tobacco smoke is not only a health problem, but also it is a matter of social inequality. This is why advancing smoke-free legislation and promoting smoke-free homes is essential, because smoke-free environments protect health, but also help to denormalize smoking, which is especially important for children, and they promote equity. And there's a lot of benefits from smoke-free policies. These strong smoke-free laws implemented at national level work well at population level. They reduce cardiovascular and respiratory events and hospitalizations for these conditions. And the hospitalizations decrease as well for both cardiovascular events and respiratory events. And after smoke-free laws are implemented at national level, several benefits in pregnancy have been observed at population level as well, with fewer adverse perinatal outcomes and fewer preterm births and low birth weight babies. And also a remarkable reduction in hospitalizations for asthma in children, as we detected in Catalonia. And in addition to secondhand smoke, we must also consider third-hand smoke, the toxic residues left on surfaces, dust, and fabrics after smoking tobacco. They are released into the atmosphere or react with oxidants and other compounds in the environment to produce secondary contaminants and remain for months. And young children are especially vulnerable because they crawl, put their hands in their mouth, breathe faster, and have thinner skin, so making absorption easier. And for example, in a study in a neonatal hospital unit, they detected nicotine on incubator surfaces when parents were smokers, and also they detected cotinine in the urine of the newborns in the hospital. So now moving to passive exposure to electronic cigarette aerosol. Of course, we don't have as much as experience as with passive exposure to tobacco smoke, but there's some studies. And we know that the cigarettes do not release harmful vapor. They release an aerosol containing several toxicants, such as nicotine, ultrafine particles, metals, carcinogenic nitrosamines, among others. And short-term effects in humans that has been stated are, for example, eye, nose, and throat irritation, cough, a headache, nausea, asthma, exacerbation, and some studies also show signs of airway inflammation after brief exposures. We still need more time to understand long-term effects of passive exposure. And regarding passive exposure to the aerosol of electronic cigarettes in pregnancy, we just have animal studies that, well, anyway, improves the exposure in animal studies. Exposure to the aerosol of electronic cigarettes has been linked to alter fetal growth, impaired lung development, cardiovascular changes, and possible cognitive effects, as you can see here. And these findings highlight the need for precaution, but it's just in animals, so very different than the results that we can find in humans. And to date, as far as I know, there's only one human study, but it's a case study that we carried out. It involved a family, a father, a pregnant mother, and a 3-year-old child living in the same home. And the pregnant woman and the child were exposed to the cigarette aerosol from the father at home. The father frequently used, almost constantly, the first generation cigarette indoors. He used the first generation cigarette because it was more discreet, but it was constantly used indoors. He was a former heavy smoker, and then we analyzed biomarkers. We analyzed several toxicants in the father, the mother, the child at several time points during the pregnancy. We also analyze cord blood and breast milk. And as you can see, we didn't find toxicants in the mother, in the cord blood, or in the child, but nicotine. We have found nicotine in the mother and mainly in the child. Nicotine was not found also in the cord blood. But we found nicotine in breast milk, which shows passive exposure, and we know that there is no safe level of nicotine for babies. And of course, this study has the usual limitations of case reports, and newer devices release even more nicotine, but gives some clues to the clinicians when advising pregnant women and families. And well, I think this is essential to continue advancing comprehensive smoke-free policies to protect everyone, especially vulnerable groups or those requiring special attention, such as pregnant women and children. Another thing is that public support for stronger policies is increasing. And something important is the legislation should cover all products. I mean, it including tobacco, cannabis, other herbs, nicotine, both natural and synthetic. And it's important also that the smoke-free laws also include nicotine analogs, which are substances with similar properties in terms of their effects or chemical structure, but they are not nicotine. And they are recently introduced in electronic cigarettes or nicotine pouches, for example. And these products are advertised as nicotine-free and are, of course, designed to avoid regulation. So it's important that smoke-free regulations include all those products. And well, in summary, secondhand smoke and e-cigarette aerosols continue to pose a major threat to public health. We must keep expanding smoke-free spaces as clean air is a right, promote awareness, and ensure extra protection for pregnant women and young children. And that's all. Thank you very much for your attention.